repetitive transcranial magnetic stimulation for OCD. In August 2018, the FDA approved TMS for OCD. And what's really interesting is that they made a point of saying that there is a lack of treatments for OCD and that the treatment algorithm really hasn't changed in the last 30 years in even their press release. So that was a bit of a game changer. And it was marketed by the company BrainSway. I have no stock in BrainSway. I don't care about the company BrainSway. The point is, in the device market, once a device is FDA approved, other providers and other manufacturers or equipment manufacturers of TMS equipment do not have to then prove that their device can treat OCD. All they have to do is prove that their device is equivalent to the one that is FDA approved. And so it's really interesting compared to any other intervention in medicine, because every other medication or intervention will become somehow protected and patentable only involving the specific device. Whereas in TMS, there are many, many providers now, and BrainSway paved the way in order to be able to provide TMS for OCD. What is this thing I keep talking about? What is transcranial magnetic stimulation? At its core, it's a method of delivering electromagnetic pulses, and those have a corresponding electrical field. And so what we're trying to do is use electromagnetism. We're trying to use your 9th grade physics in order to modulate brain activity and ultimately change brain activity and brain function. And ultimately, this is, oh, that wasn't supposed to disappear. And that wasn't supposed to be cut off. Sorry, guys. This is Faraday's principle. And so it's essentially a way of expressing what the corresponding electrical current would be in response to a magnetic field. And so in a less abstract context, what we're trying to do is we're trying to generate a magnetic field in order to target a particular part of the brain. And so we do that by having a magnetic coil through which we release a very large amount of electricity. So essentially just a fancy expensive capacitor. And so you release all that electricity, it goes through the coil. Hopefully you can see my mouse, I'm not sure if you can, but you will induce an electric current in the coil, which has a corresponding magnetic field, which goes around this coil kind of like a donut. And then underlying it would be a corresponding I field. So your B field is going around like a donut, and your I field, your electrical field, is going around like this. These are the early days of TMS. That makes it very hard to be focused. You've got this kind of diffuse electrical field in the brain. Might be useful for some things, but maybe not optimal for others. And so they started to refine how you could actually target. And one of the first big developments in this area was by using figure-of-8 coils. So instead of having a single circular coil with that single circular corresponding electrical field, you now have 2 intersecting magnetic fields and their corresponding electrical field, which has a peak. And so what you can do is you can be more targeted when you're targeting the brain, meaning that you can elicit an electrical current that is sufficient for membrane depolarization and driving neuronal activity only at that place. And then as you drop off, there's a very sharp drop off in the electrical field so that you don't get activity induced in neighboring neurons that you're not trying to target. So that's pretty cool. This is a fancy way of showing that, where you essentially have a directional current if you have a single coil. And if you have intersecting figure-of-8 coils, you get a directional current with corresponding very small opposite directional currents next to it. And these are volt by meter squared, which is how we kind of express the electrical field that's induced by the magnetic field that we're trying to induce. That's all the physics I'm going to be bringing up today. That's the end of it. We're going on to slightly more clinically relevant things. Pretty pictures first and foremost. You'll recognize that this is not a head, this is an arm, but it's a very pretty representation of what I was just trying to show you, and I like to show it, where in targeting the median nerve, which is a relatively small nerve in the arm, you can be very precise and targeted it with these directional swirls that ultimately are the currents that are induced by the magnetic field. This is an example from my own lab where we're targeting something called the dorsolateral prefrontal cortex, which is the dominant target in the treatment of depression. It has been studied in the treatment of OCD, and there is evidence for efficacy, but it is not the FDA approved target nor the Health Canada approved target. Here you can see that there's actually the 2 coils that are generated in this neuronavigation system. We have fiducials, which are just reflective pieces of plastic that people put on their heads in order to be tracked by an infrared camera so that we can actually be very precise in our targeting and be confident that we are targeting the right region of the brain repeatedly and consistently over time. And you can see there's this electrical field that is targeting here the inferior frontal gyrus and partially middle frontal gyrus, and the drop off in the electrical field. And I always think it's kind of fun to go back and remind ourselves that while this may be new in OCD and new in psychiatry, electromagnetism as applied to neurological function is not new. It actually has a very long history. So going as far back as this gentleman, who is Dr. Thompson, he was a professor in mathematics and electromagnetism. And in 1910, he thought it'd be fun to put his head in this thing and see what would happen. And lo and behold, he was able to induce flickering lights even when his eyes were closed. And he reported some of these early attempts to do neuromodulation with electromagnetism. Shortly followed by this man, Dr. D'Arsonval, who used alternating currents instead of a single magnetic pulse as Sylvanus used. And he was able to induce what he described magnetophosphines. And phosphines are the same thing that Sylvanus was describing, but it's essentially these flickering lights. They're prototypically kind of a bluish green because that is what we're most reliably able to induce in terms of color in visual cortex. But you could induce brain function that was extracorporeal, so outside of the brain. You can drive specific brain function as early as the 1930s and the 1910s. Not very specific, not very useful for clinical applications yet, but it then continued to grow. And so in the 80s, so fast forward 50 years, there started to be a more focused effort to try and understand in the human and not in a model organism how motor cortex resulted in output. And the motor cortex was what was studied because, one, it has a measurable output. You can actually measure in the muscle, which makes it reliable and easy to look at latencies and look at how the brain is organized. And here you see 4 individuals where they're stimulating motor cortex and measuring a corresponding muscle output. And this very shortly after led to the development of the very first TMS machine. So Robert Barker published this in The Lancet, and you can see it was these old single coil that I began the presentation with. But even with that single coil, its diffuse electrical field is enough to elicit what's called a motor evoked potential. And so you can use this as a tool to map the brain, to study brain function non-invasively without having to incise skin, muscle, bone on the way to brain in order to do these kinds of studies. So it's a very, very powerful tool that's been used in neuroscience and it's used in a variety of contexts. In the neurophysiology world, it is very commonly used to study stroke, rehabilitation, and increasingly it's exploded in the psychiatric field because we've been able to use it as a treatment. So for aim 1 or objective 1 of the presentation, just a basic understanding of TMS is its physics, but also what it's doing on a physiological basis. So I've already told you that it induces a magnetic field, which has a corresponding electrical field. Excuse me. The brain is an electrochemical organ, so you can drive activity. Excuse me. As obvious as seen in that motor evoked potential in the motor system. But it is our most evidence-based treatment, forgive me, for OCD. And what we're trying to do when we deliver it for treatment purposes is we're not trying to induce single action potentials or single regional depolarizations. We are trying to use patterned energy to leverage the intrinsic properties of the brain and drive something called synaptic plasticity. And synaptic plasticity is an umbrella term that's used to refer to a lot of different things. And I'm not going to go into the specifics. I'm just going to use it in its umbrella sense, which is that it is a method, or it's an endogenous biological process of adaptation to experience and activity. So at its simplest, kind of as described by Donald Hebb in 1949, neurons that fire together, wire together, and neurons that do not decouple. And so if we can drive activity, we can drive their long-term firing patterns together, so we can lead them to have stronger connections. And if we decouple them, we can lead to weaker connection over time. And what we do with TMS is, because, as you saw from everything I've shown you so far, it's actually quite superficial. We can only actually get about 3 to 5 centimeters below the surface of the brain. And what we're trying to do is we're trying to use the reciprocal connections within the brain. So these cortical targets all have subcortical regions with which they communicate. And that's crucial for OCD. And again, on this basic mechanism, how do we model plasticity? How do we know that our protocols are actually inducing change in the brain? Most of the work has actually been done in the motor system because, again, we have a measurable output. So we can deliver specific protocols, specific patterns of TMS pulses, and look at whether or not the motor output goes up or down. And that gives us a crude measure of plasticity. Has there been an adaptation that has occurred in response to the stimulation that is leading to a measurable change in the output? And so you have your pulses that you're delivering to motor cortex. That then goes down through the spinal cord to the motor neurons and then to the muscle, and you can measure what's called a motor evoked potential. This is just an example from my lab showing that you can deliver something called intermittent theta burst stimulation, and your motor evoked potential after stimulation goes up, stays up. If you deliver a second one, it goes even higher. So it's this idea that we can deliver multiple rounds of stimulation to change the brain. You can do something called a recruitment curve, which is, instead of using a fixed intensity, you can kind of see how the motor representation goes up and plateaus, so that the more brain you excite, right? So the more neurons are at that threshold, you get to a point where they're no longer involved in the motor response. And then you can do your plasticity protocol, and you can show that changing dramatically. So you can be confident that your protocols are actually inducing measurable changes in the brain, and you can use that to inform how you're going to treat. Enough of the abstract. Let's see what TMS is. This young man here has never received TMS before. He's about to get it. This is 4 years ago before I got here. It's not true that I've never received TMS before, but this is 10 hertz TMS. So this is the common target for depression, the dorsolateral prefrontal cortex. This is our figure of 8 coil. And here comes a train of 10 hertz stimulation. And you'll see my chin wag a little bit because the stimulation is going through muscle on the way to the dorsolateral prefrontal cortex. There are a couple things that I want to highlight. You can hear that's the 10 pulses per second going. A couple things I want to highlight. One, I'm in no distress. This is actually not uncomfortable. It is actually quite soothing to a certain extent. What's kind of annoying is that you have to wait 26 seconds between trials. So the standard way of delivering TMS takes 37.5 minutes. So there I am waiting for another train, and here it goes with a good chin wag this time. What I'm going to show you next is something called intermittent theta burst stimulation, which is kind of changing how we think about TMS, because it uses a more biological rhythm to the brain. 10 hertz was more or less an engineering problem where they couldn't get it to go faster without breaking the coil because the coil heats. And so in the early days of TMS, that's how fast you could go, and that's the best we could do to actually modulate the brain. Theta burst, so I have never received theta burst stimulation, so you can see how surprised I am when I get this. Here it goes. Oh, this is the wrong video. I'm very sorry. My sincerest apologies. Theta burst stimulation sounds like this. I'll try and imitate it with my microphone. It's triplets going at 50 hertz at 5 hertz, which is the theta rhythm. And had I put the right video, you would have seen that my entire face moves quite convincingly with every triplet and every pulse. And it's a protocol that delivers essentially the same amount of neural change, if we can be so reductionistic, in 3 minutes as opposed to, or is this it? Here we go. This is theta burst. So you can see there's a lot of muscle movement because the triplets are compounding on each other. The specific rhythm is such that GABA autoreceptors are not able to clamp down on activity, and so you get building activity with each triplet. And so again, with 3 minutes instead of 37.5 minutes, you're able to induce change in the brain, and it's becoming our dominant protocol for the treatment of depression and increasingly for OCD. Gold star, because this will be on your exam at the end. What is TMS indicated for? TMS is Health Canada and FDA indicated for major depressive disorder for about 20 years now. Migraine, certain types of migraine, that was shortly after in around 2005. Obsessive compulsive disorder in 2018, and smoking cessation in 2021. There are no other approved indications for TMS. There's lots of active research, but nothing that has met the bar for FDA approval. TMS is just a way of releasing the energy that goes into a coil. Now, the configuration of the coil, as I've already told you, has a lot to do with what the electrical field is going to be and what targets you can actually target. All the way on the right here is a traditional figure of 8 coil that's used for the treatment of depression. But there are a variety of other coils that have been pioneered that have very interesting and engineering heavy electrical fields, shall we say. So you can imagine this H coil is designed to do something very similar to the figure of 8 coil, but it's more patentable and protectable. The H7 coil, as you can see, is designed to get quite deep into the brain. And so might be more relevant for things that have targets that you can't hit very far towards the surface of the brain. And this H4 coil is the one used for smoking cessation. As I was alluding to earlier, no one company has cornered the market, and that's because in the device world, all you have to do is show equivalency to what you're trying to do. And so Neurostar was the first, and then there are a variety of others that have come. These 6 all are capable of delivering intermittent theta burst stimulation. These 5 are not. These are more in Russia and in Eastern Europe and in China. In Calgary, our equipment is all MagVenture for the HS program, but the research arms use MagStim as well. And we would like to get a brain sway device, but it's very expensive. Gold star, question 2. What are the risks of TMS? The single greatest risk in TMS is of inducing a seizure. And that's quite simply because the brain's an electrochemical organ and you're delivering energy to it in a pattern that can induce a uncontrolled electrical activity, which is the definition of a seizure. In individuals who are not otherwise predisposed, that risk is actually very, very low. We're talking 1 in 1,000, 1 in 10,000. But if you have a seizure disorder, if you have an intracranial lesion, if you've had a severe brain injury, or if you have uncontrolled alcohol use and you're predisposed to seizures through any of those means, the risk becomes unacceptably high and you should not have TMS. It is a contraindication for TMS. The traumatic brain injury piece is very gray. What's been excluded from the trials is anybody who's had a brain injury with a loss of consciousness of over 5 minutes. That's a bit arbitrary, but that just for your understanding is kind of how we set the threshold. It's actually quite a low threshold. The other risks are that these magnetic fields can heat or move metal, and so you don't want intracranial metal. And you have to be very careful because metal workers, people who do grinding or soldering or a variety of other things with metal, may have metal in their eyes without knowing it. They may have had a shard come off and they went to the emergency department. They took out what they could actually see, but there may be metal left there. And there's a very strong risk that if you are not careful and do not get an X-ray to rule out any metal in the head, that metal could move and cause a lot of damage or heat. Similarly, if somebody's had an aneurysm clip or a cochlear implant or any other kind of intracranial metal, no go for TMS. This is an absolute contraindication. The next question that people always come up with is, what about dental hardware? I mean, I've got fillings, I've got a brace. It's not intracranial, it's heavily anchored into bone, it's safe. So that is okay. Side effects with TMS are actually quite favorable. It's much less problematic for most people than medications, than a variety of other treatments. The most common would be a headache, and that occurs in 65% of people, but that's very much depending on your definition. In our most recent trial for depression, 90% of people reported a headache at some point. The reality is they were very mild headaches and nobody really minded them, but they are quite common. As you saw when I had the stimulation, the energy does go through, again, skin, muscle, bone on the way to brain. And so it can activate sensory fibers in the scalp, and scalp tingling or discomfort is commonly reported in about 60% of people. But again, that's something that people habituate to very quickly. It's usually only the first couple of treatments and goes away. What we say to patients is that if you are one of those people that finds it uncomfortable or gets a headache, please feel free to use Tylenol, ibuprofen, whatever works for you and is safe. And you don't have to wait until you have the problem. You can pre-treat in order to prevent it being uncomfortable or unacceptable. There are a range of less common side effects, and those include things like fatigue, worsening insomnia, nausea, vertigo. That all happens in less than 10% of people, depending on the study. We're talking 7 to 9% of most people, and in most sham-controlled studies, which are what we use to prove that a treatment works. So essentially, you have a wand over the head that makes all the right sounds and all the right noises and vibrates and does everything except stimulate the brain. People don't experience a higher rate of those side effects. So it's something to do with sitting there, being still for however long the treatment protocol is. And we know that placebo can induce side effects as well. So 7 to 10% of people will have these less common. Common ones are headaches, scalp fiddling, gold star. Remember what that means. So TMS safety. How do we try and make sure this stays safe? How do we keep it within those acceptable side effects and seizure risk numbers that I quoted? This is the motor homunculus, and what it's what it's showing you is here on the motor strip. You see that there's organization of the brain that is homotopic, meaning that you have representation of the brain on either side, representation of the body, pardon me, on either side, in the form of the homunculus, where legs are down deep in the fold here, and you have a very large hand knob, which would be right around here, and then face, lips are very, very large as compared to other parts of the body. And so what we do to maintain safety is we deliver pulses relative to a personalized threshold. What does that mean? We use the motor cortex in order to determine what the threshold is to involuntarily move a muscle. And you can do that as an active motor threshold or a resting motor threshold. And so what's commonly done in depression is that you target abductor pollicis brevis and you move it. And so you find the minimal intensity that it takes to move it 5 times out of 10. And that gives you your motor threshold. In OCD, as we're going to get to the anatomy in a little bit, you're actually targeting deeper in the brain. And so you use the foot in order to determine your resting motor threshold. So it's always a little bit of fun. You get people to take off their shoes, their socks, and you target the brain until you can move soleus and gastroc, and you can actually get their feet to twitch. I'm not going to show you my feet twitching. That would be less fun. So why do we use that? Because it's a personalized measure of cortical excitability. It tells us what that individual's cortical excitability is and what would be unsafe to go beyond that. Because if we drive it to the point of delivering a seizure, we've gone too far. But if we keep it within a band around their motor threshold, we know that we're operating in a safe range. Gold star. Things that change cortical excitability are medications, substances, and sleep. So if you change somebody's medications as they're receiving rTMS, you are going to change their motor threshold. You're going to change the intrinsic safety properties of the treatment. If you have somebody that has an uncontrolled substance use disorder or is not being quite honest with you about their substance use, they will have an undue risk of seizure. So if you have somebody going through a course of rTMS, you can change medications, that's fine. You have to tell the treatment team that medications are changing, otherwise the safety criteria have changed and the goalposts have moved without telling the treatment team. Things that do not change cortical excitability are things like symptom changing, worsening, psychotherapies, and mood state. So you can certainly continue a psychotherapy, you continue your ERP as you put somebody or refer somebody to TMS, and that's not something that you have to worry about. You just have to notify the team if you are making any changes to medications, because again, motor cortex excitability is an index of global excitability, and it will change with medication changes. Yet another gold star. What makes TMS work better or worse? Better is not clear. We wish we knew. We have a variety of biomarkers that are under study that use fMRI, that use plasticity measures, that use a variety of things to try and predict who will do better with TMS, but it remains unclear. Are there particular medications that make TMS work better or worse? Again, on the better side, it's unclear. I'm going to tell you about some data from my lab at the end of the presentation that's, I think, quite convincing that we can make it work better, but it's going to depend on the disorder, and that data is only in depression to date. There are unambiguously things that make TMS not work well, however, and those are things that change membrane potential. So those are things that change a neuron's ability to fire. There are things like benzodiazepines and pregabalin and gabapentin, because those are GABA receptor agonists, partial agonists and allosteric agonists, and anticonvulsants. This is important, particularly for your population, because a lot of your population will be using benzodiazepines or pregabalin, gabapentin at some point, because they're commonly used to treat anxiety. So at its base, TMS is a circuit level intervention, and we need to have a circuit level understanding of OCD. We don't really understand what OCD is. It's probably not one thing, but we know it has something to do with thalamocortical loops. So thalamolimbocortical loops are somehow contributing to the intrusive thoughts, images, and urges. And we understand that to be a treatable target here in the ventromedial prefrontal cortex. Now that includes the orbitofrontal cortex and the medial prefrontal cortex, the anterior cingulate here. So we believe that this prefrontal cortex control over the amygdala and over this thalamocortical loop is a way of treating depression and OCD. And that is why in the history of OCD, very, very severe cases of OCD have been treated with cingulotomies. So targeting this part of the cingulate and anterior cingulate cortex. We can now do that non-invasively with the proper configuration of coil. And so this is the pivotal trial that led to FDA and Health Canada approval, published in 2019. The approval was granted in 2018, as you saw, but publication is slow. And I'll walk you through what they did for this study. They ultimately enrolled 100 individuals, and they had a very tight network for identifying people because they only excluded 31. That's kind of unheard of in a clinical trial. And went on to treat 47 in each group because a variety of people withdrew. It was multi-site. It was over 11 sites, 9 in the US, 1 in Canada, 1 in Israel. It was run from 2014 to 2017. It was 6 weeks of treatment, of which the first, so I should specify, when we speak in weeks in the TMS world, we're talking Monday to Friday. It's not a 7-day-a-week treatment. So 6 weeks corresponds to 30 treatments, but because they like to make things unique, for OCD, it's actually 29 treatments because you consider the first treatment as being an assessment. To be eligible, individuals had to have moderate severity OCD, and that was defined as a Y-box, so the Yale-Brown Obsessive Compulsive Scale score of 20. And individuals had to have failed an SRI, so a medication of some kind to treat OCD, or cognitive behavioral therapy, and they had to continue on the medication or continue getting cognitive behavioral therapy throughout the treatment. They used a personalized symptom provocation, which was defined as a 3 to 5 minute provocation to activate the relevant neuronal circuit. You can my disdain and my disdain is my lack of belief that this matters is palpable. I'm sure you can tell. But because this is just a way of ensuring that their IP is implementable, that they have to create a package deal where you need to have the training to do the provocation and the device in order to do it. So I think this was all just IP protection, but nevertheless, this is what they did. And it had to achieve a SUDS of 4 to 7 on a 10-point scale. They used the coil that I showed you earlier. This is the H7 coil. Again, because I'm not promoting brainsway devices, multiple other companies then followed suit very quickly and showed, well, we can induce the same field with a different configuration with our own coils. And so it's not just the brainsway devices that can treat OCD. But they use this configuration because, as you can tell, instead of being angled like this, like the figure of 8 coils that I showed you earlier, it's angled quite deep, because instead of having a current here, you're trying to induce a current down here in the ventromedial prefrontal cortex. So it's deep TMS is the term that's been used to describe that. They used foot to determine motor threshold. They targeted the medial prefrontal cortex. They delivered their trains at 20 hertz and 100% of motor threshold. These were 2-second trains, which corresponds to 40 pulses over 2 seconds, with 20 seconds in between each train, which to me seems kind of odd that somebody would be able to maintain that provocation, because that's what they were told to do, to maintain that 4 to 7 SUDS for 20 minutes as they're getting pulses at 100% motor threshold, which is why I'm not sure it actually matters. I think the brain stimulation matters more than the symptom provocation, but nobody's done a trial to try and tease out what the most important part is. And 2,000 pulses per treatment for 29 treatments. This is their data. These are change scores on the Y box from beginning to end. And you can see that there's a large separation that begins by about 3 weeks and is maintained at 6 weeks and 1 month post follow-up. This was a difference in their linear mixed effect models of 6 points on the Y box, which is quite large. And here they've shown histograms to try and represent the percent change on an individual basis. And so what you'll see is on top is the sham group, and on bottom is the active stimulation group. And you can see that there is there's a important sham effect that can happen. So there's an important tail in the sham stimulation group, whereas there's no distinct modality to the active stimulation group. They had a response rate of 42%, and they defined response as a 30% improvement. But one thing that I think is important to highlight is that there are numbers below 0. And that's important because every once in a while, we see patients that actually get worse with treatments, and they're incredulous, and we warn them that this can happen, but any treatment can be associated with an adverse direction, an adverse clinical outcome. Thankfully, it's quite rare, but it is a small number of people do get worse with treatment. So that's the clinical trial. Let's look at some real world efficacy data. When people are bought in, they believe they're going to benefit, there's no possibility of sham. What does treatment actually look like when there isn't that blinding component? This was 167 individuals in I believe it was 18 different treatment sites. They were delivering treatment with the H7 coil targeting the medial prefrontal cortex. They were either using the 20 hertz protocol that I just described to you as part of the clinical trial, or a small number were using the intermittent data burst stimulation protocol that I showed you earlier on in the presentation. They all used symptom provocation as part of the protocol. And unlike a clinical trial where we encourage everyone to finish the treatment protocol, this is real world, and so people can drop out whenever they like. People had up to 29 treatments. This is real world data where 30 sessions is 6 weeks. And you can see that on average, there's a 30% reduction. But because it's real world and people are actually paying for this, you can go on to as many as, I didn't put the slide, but there were as many as 120 treatments. So people can pay for as much as they are willing to receive. But this would be the typical 29 treatments. And what that means is that approximately 72% of people who are assigned to receive this treatment in the real world achieve a 30% improvement on the Y box. and that is actually sustained in 52% of people after a month. Now, of course, this is the combination of treatment itself and expectancy bias, as well as every other treatment that's going on at the same time. But this is very encouraging. Now, to make sure we have lots of time for questions, I'm going to be very brief when I tell you what we're trying to do in my lab. But I'm going to bring you back to this idea that I told you about at the beginning, that TMS being the most established non-invasive neurostimulation treatment for a variety of neuropsychiatric conditions is the place where we can make the most difference. If only we could understand what exactly the treatment was doing and whether or not we could enhance it. And we think the treatment is working via synaptic plasticity, but nobody has ever explicitly tested this. And so what my lab is doing is that we're trying to use pharmacological adjuncts that are specifically chosen for their participation in the physiology of what's happening in synaptic plasticity to see whether or not we can actually improve outcomes by improving the physiological effect. And we do that with things that target the NMDA receptor, because the NMDA receptor is key to synaptic plasticity with these kinds of TMS. Our work has largely involved this compound called D-Cycloserine, which you may be familiar with because it has also been used as a as an adjunct to ERP in OCD. The results have been mixed. But even in OCD, it's used for the same purpose because it is an NMDA receptor partial agonist. So the N-methyl D-aspartate receptor is a glutamatergic receptor that is very, very important for calcium entry into the cell and synaptic plasticity and reconsolidation in ERP, or LTP in my context, long-term potentiation in the context of TMS. At low dose, it agonizes, meaning it allows more entry of calcium into the cell, and at high dose, it antagonizes. And what makes it interesting is that it crosses the blood-brain barrier, so you can actually get it into the brain where it's needed when you're delivering your trains of stimulation. We weren't quite as lucky. We had to interact with 270 individuals to get 50. They only needed 131 to get 100, but we screened 270 individuals to ultimately recruit 50. These individuals were randomized to either that intermittent theta burst stimulation with placebo or intermittent theta burst with D-Cycloserine, and they went on to receive their treatment courses. We use what's called the Montgomery-Åsberg Depression Rating Scale, which is a depression score, and we showed that by combining this intermittent theta burst stimulation with D-Cycloserine, we could dramatically improve outcomes. And this corresponds to an effect size of 0.99, which is skeptics will find hard to believe because it's very, very large compared to an active treatment. But it is suggesting there is something important going on, that we can actually improve the effects of stimulation. Clinical response and remission, as you may know, are defined differently in depression. Response is a 50% improvement, and remission is no more functionally impairing depressive symptoms. And we were able to show that the combination of this intermittent theta burst stimulation with D-Cycloserine dramatically improved outcomes in our patients. What is kind of cool is that we could also do what's called, or we could also look at adherence to the study protocol to determine whether or not this was just chance or an additive effect, or whether it truly was a synergistic effect between drug and stimulation. Because participants were asked to take the drug at least an hour before stimulation, so that the drug had enough time to absorb, distribute, get to brain. You can see that the placebo group, there's no relationship with how adherent they were to the protocol and whether or not they got better, whether they responded or not. So it's not a question of whether or not the patients are better or more involved or have greater expectancy bias in the trial. It really was only in the D-Cycloserine group, if they took it closer to that 1 hour mark, and you'll see that less than 50% of doses were actually taken as requested. If they took it closer to that 1 hour mark, they stood a higher chance of actually benefiting from the treatment. So what are we doing now? We're actually trying to determine whether or not this is true in OCD as well. So we are running a study pairing TMS with D-Cycloserine in individuals with OCD that have not benefited from medications or cognitive behavioral therapy. And it's very similar to the depression trial, in which individuals will all receive, actually that's not true. I was going to say they will all receive active TMS, but because D-Cycloserine has itself shown some efficacy in OCD, there is a small sham group. But anybody who doesn't have at least a 30% improvement goes on to receive an additional 4 weeks of TMS at the end. So everyone gets at least 4 weeks of TMS. Some get as much as 8 weeks of TMS. And with that, I think I've left enough time for questions. I just want to thank the people who are instrumental to the work, my funders. Jaden did a lot of the depression work. Maya and Ben have done a lot of the physiology. And these are my imaging collaborators. And I'll open it up to questions.
Wonderful. Thank you, Dr. McGirr. If you would like to pose your questions, please do so. While you're doing that, I will just put up the post-evaluation questions. You find them.
What do people think? Would you actually recommend this treatment for your patients if?
If anybody would like to unmute themselves and pose a question, please do.
I'll just read the question out in case people are doing other things. Is there any evidence for this type of treatment in children or adolescents? You know, there is and there isn't. It's been very challenging to do good work in children and adolescents because there's a reticence to doing sham-controlled studies. What has been very unfortunate is that the large sham-controlled study in youth for depression ultimately did not show superiority to sham. And both groups had, this is for depression, both groups had very, very favorable outcomes. And I think to a certain extent that shouldn't be surprising because there's a lot more to the treatment than just brain stimulation. If you have somebody who is anxious, depressed, withdrawn, and you have them come and interact with somebody every day for 6 weeks, there's so much more than just stimulation going on. In OCD, there is quite a lot of open label data to suggest that there is benefit, but there has not yet been a sham controlled study to show that it is superior to simply getting out and getting exposed. My sense would be that particularly in the child population, this would be an important thing to test because I think there is a certain amount of those youth that have early onset and have very severe cases of OCD are less likely to respond to ERP or be able to engage in ERP. And I think OCD would be, TMS would be a very important tool for those kids. But especially then you run into the ethical issue of sham in that very treatment refractory population. And so these are very hard studies to do in that population.
Thank you.
My pleasure. There is, as you may know, I'm going to get the name wrong, a child and adolescent brain health center being constructed in which there is going to be a TMS component. And my understanding is that they will have a brain sway device and that OCD is one of the main areas of interest and that there will be OCD treatment offered, but it'll be open label. It will not be demonstrating efficacy. Have you observed the results of this treatment for individuals with obsessive compulsive personality disorder, or does that fall under the umbrella of OCD? I have never read a study specifically focusing on obsessive compulsive personality disorder. It is not included in the trials for OCD. In my practice at AHS, we of course see a variety of people who have obsessive compulsive personality disorder with depression. So for the dorsolateral prefrontal cortex target, we've certainly seen a lot of that, and they do benefit. They don't benefit more than all comers, but they do benefit. And we do have data to say, and this may be of interest, we do have data to say that TMS to the dorsolateral prefrontal cortex reduces neuroticism, and it does so in proportion, but at a higher, well, I'm going to say that convolutedly. It improves neuroticism and not just proportional to depression. So it is having a direct effect on individuals' neuroticism, which one might imagine would be related to OCPD.
Does anybody have any questions? Any more questions at all?
Any research on the horizon related to this treatment and Tourette syndrome? Yes, so I know of a couple of different studies in a couple of institutions, including our own. And so Frank McMaster is doing work on Tourette syndrome and tics with TMS. And so again, that is in children on top of that, so it's not in adults, which is nice. And it uses a fancy robotic TMS device so that they can target accurately even while children are having tics, which is really kind of interesting. So it actually tracks and moves and maintains the target properly. So that is not yet, of course, Health Canada approved. It's still very investigational. But as with many other areas in TMS, the evidence is growing quickly, and hopefully it can be made available soon. Mentioned substance use and what are the requirements for limiting substances during this type of treatment. So any active substance use disorder is, of course, a contraindication. We require 3 months of remission from a substance use disorder in order to enroll somebody in a clinical trial, and we use the same standard at AHS. And we are most worried about alcohol, but the others are also very relevant. In particular, we have had colleagues, although the data is not published, we have had colleagues who have treated in the thousands of patients present data at conferences to suggest that cannabis use disorder is associated with a very low rate of clinical response and remission, again, for depression. And so that's not a safety issue more so, it's an efficacy issue. So I may have misinterpreted the question. The requirements would be for alcohol, the Canadian Healthy Drinking Guidelines. We would require people not to go above that because that would put them in undue risk, if that is what you actually meant by the question. Okay. Well, thank you so much for having me, guys. I really appreciate being able to tell you about TMS and your interest and your great questions.